Okay, welcome. This is going to be a long video, and so if you don't want to watch the whole thing, you can go down to the description, and down there are the timestamps if you want to move forward to a section that you have more interest in. With that said, welcome to this video on cardiovascular disease and the microbiome, with information and perspective you'll find nowhere else. Such as that cardiovascular disease is not all about LDL cholesterol, as Big Pharma would have you believe, or that HDL is more complicated than just a number, and that there are clear non-pharmacological approaches you can take to address the many factors and metabolites within the spectrum of cardiovascular disease. We will not be touching on a number of topics in order to limit the scope. My goal is that you will walk away with a more critical, analytical, and intelligent way to think about the world's #1 killer, a perspective which addresses the root cause. Now first, before I lose you, let's start with some hard-hitting data. From this paper, which is literally entitled, LDL Cholesterol Does Not Cause Cardiovascular Disease, a comprehensive review of the current literature, we get quotes like this, talking about exposure response in cholesterol-lowering drug trials, and this, highlighting the 30-year follow-up to the Framingham Heart Study, which reported that, quote, for each 1 milligram per deciliter drop in total cholesterol per year, there was an 11% increase in coronary and total mortality. And this, quote, numerous Japanese studies have found that high LDL cholesterol is not a risk factor for coronary heart disease mortality in women of any age. And this last quote, where low LDL is correlated with heart attacks and death, that's low LDL. Then there is this large review of 19 studies which included over 68,000 people from the general population over the age of 60. Their conclusion states, quote, high LDL cholesterol is inversely associated. In other words, the higher the LDL cholesterol, the lower the mortality in most people over the age of 60. This finding is inconsistent with the cholesterol hypothesis. Since elderly people with high LDL cholesterol live as long or longer than those with low LDL cholesterol, our analysis provides reason to question the validity of the cholesterol hypothesis. Moreover, our study provides the rationale for a reevaluation of the guidelines recommending pharmacological reduction of LDL cholesterol in the elderly as a component of cardiovascular disease prevention strategies. Since they want to reevaluate the guidelines recommending pharmacological reduction of LDL-C, I want to reevaluate our understanding of how statins potentially provide benefit. This paper is loaded with references attesting to the antioxidative and anti-inflammatory benefits of statins. They have many interesting quotes like this one, which states, quote, there are findings supporting the anti-inflammatory effects of statins, including the reduction of the levels of C-reactive protein, CRP, in subjects taking a statin regardless of the levels of decrease in LDL cholesterol. And speaking of CRP, here we have a study looking at the combination of inflammation as measured by CRP, cholesterol, and risk of a first heart attack. You can see that the highest risk is for those with the highest CRP, aka inflammation, combined with the highest cholesterol. This is one of many studies that demonstrate this. Looking at inflammation and oxidation makes much more sense than just cholesterol, especially when you consider that about half of all cardiovascular events occur in apparently healthy people with low to average levels of LDL. That's half. A flip of the coin is not predictive. So, is taking statins worth the risk, considering the many roles cholesterol plays in the body, such as serotonin function, think depression and anxiety, LPS clearance, endotoxemia, other brain functions, and sex hormone production. That's estrogen and testosterone for both men and women. How much do you value a robust lifestyle? And not to mention the side effects like reduced CoQ10 resulting in muscle cramps, fatigue, etc. Wouldn't you rather address the root cause? What we think of as narrowing and hardening of the vasculature, aka cardiovascular disease, begins with oxidation and inflammation. There is a mountain of evidence to show this from researchers from all around the globe. It's not the cholesterol per se, which is crucial to our being. It is the cascade of events following the oxidation of the cholesterol on LDL, which then triggers an inflammatory response. It is ultimately a protective response. It's like if you get a wound in your skin. The scab that forms is a protective response as well. Would you blame one of the factors that forms the scab? Instead, we should aim to avoid the initial insult. And dietary cholesterol is not the bad guy either. I have heard this fallacy a million times over the years. The general public is simply confused, and it's not their fault when it comes to dietary cholesterol. Here we have a comprehensive review looking at dietary cholesterol and its correlation with cardiovascular disease. In study after study after study, the conclusions were that eggs either had no effect on the risk of cardiovascular disease or actually showed benefit. Whether it's in blood pressure, with a study of 11 years at 7 eggs per week showing a 29% reduction in mortality, or multiple studies showing an increase in HDL from egg consumption, or the case study of an 88-year-old individual who consumed 25 eggs per day and had no heart problems and normal plasma cholesterol levels. Dietary cholesterol, due to mechanisms of absorption and excretion in the healthy, does not translate to high serum cholesterol or cardiovascular disease. What a number of these studies did find, and which I often say, is that carbohydrate intake increases cholesterol and saturated fats are associated with cardiovascular disease. The confusion lies from the 1960s when dietary guidelines were established to limit cholesterol intake to no more than 300 milligrams per day. These guidelines were eliminated in 2015 as the data showed this thinking to be flawed. So even officially, there is no upper limit for dietary cholesterol intake. If the 1960s guidelines were based on fact, then I would be in trouble. I've been eating on average 2 eggs per day for the past 40 years. Those 2 eggs alone exceed the 300 milligram threshold. Never mind the rest of my diet. But I haven't cared what the system has been saying for my whole life. For example, I don't have a primary care doc, and nor do I want one. This here is from 2014. Here are a couple important markers to pay attention to. Hemoglobin A1C is an excellent marker for overall health. CRP is another good one as well, which we saw as part of the inflammation theme of this video. You don't want high inflammation, you want it rock bottom like we see here. And from this same report, uric acid is a decent marker, and not just for kidney health, as you'll learn later. Then we get to the bottom. You see my lipids, and I'm quote-unquote high for LDL. Now, a regular primary care doc would be most likely forced by their group to recommend a statin to me in this instance, whether they believe in it or not. But I don't care. That's stupid, as you'll come to learn. What's far more important is my level of oxidation and inflammation. My HDL count is not particularly high, but again, we want quality over quantity, which you'll also learn. Here I am again 5 years later, with pretty much the same numbers. And I still don't care. No drugs for me, thanks. And here I am again 3 years later, after all the eggs, red meat, etc. that I eat, with again pretty much the same exact numbers. And I still don't care. This was a couple years ago. I just turned 55 last week, and for these past 8 years I just showed you, my numbers have been the same. And I'm still kicking. My exercise regimen and diet over these past 8 years has been pretty much the same, and my supplement routine has probably even gotten more intelligent. My blood pressure, probably the best marker for cardiovascular health, is always on average about 116 over 70 something. What I am concerned about is my level of oxidation and inflammation. And that story starts with the microbiome, as you will soon see. But first, let's take a look at why I don't care about these numbers. First, we start with a few slides on LDL. We already covered how dietary cholesterol does not determine serum cholesterol. This process is regulated by the body between absorption and excretion. The body knows what to do if you take care of it. About 75% of the serum cholesterol is synthesized in the liver. However, excessive sugar intake, especially high fructose corn syrup, can push the liver into making more lipids. See my presentation on liver health. Also in that same presentation is the important role the microbiome has in cholesterol elimination via bile acids. In a dysbiotic microbiome, there are too many primary bile acids and not enough secondaries being excreted, further disrupting this balance. Therefore, the microbiome can not only serve as a source of inflammation in the vasculature, but can contribute directly to serum lipid issues. The good news is that if you take good care of your microbiome, it will take good care of you. If you don't, and I know I'm simplifying things here, a series of pro-inflammatory responses ensue in response to oxidized LDL embedded within the vasculature wall. Returning to CRP, again it's a non-specific marker for inflammation, we see figure 1. We have 14 studies picked out of many more which show an absolutely clear correlation between increasing CRP levels and risk for cardiovascular disease. In every case here, you see a stepwise progression in risk as the levels of CRP increase. No deviation. That's consistency. It is well established that CRP is an independent predictor of future cardiovascular events, whose impact is at least equal to that of LDL, HDL, blood pressure, or smoking. You know all about the last 4, but how often do you hear about inflammation in the context of cardiovascular disease? Here we see a simple figure to illustrate a powerful point about oxidation. As these subjects progress from acute heart attack down to unstable angina, to stable angina, and to healthy controls, we see a significant decrease in the amount of oxidized LDL between these cohorts. This emphasizes the importance of the quality of your LDL, oxidized or not, instead of the quantity. And in fact, these authors go on to state, quote, serum levels of total HDL and LDL cholesterol did not differ among these patient groups. In another way of looking at oxidized cholesterol, these researchers analyzed the lipid composition of red blood cells in heart failure versus control subjects. They found that the oxidized cholesterol, 7-ketocholesterol, highlighted in B, was dramatically higher in the red blood cells of heart failure subjects. As you can see in A, they show visually that it is an oxidation product of cholesterol, which accumulates as a consequence of oxidative stress. Data shows that 7-ketocholesterol is considered an important metabolite for monitoring cardiovascular disease outcomes and mortality, as well as for predicting the incidence of cardiovascular disease events in general population. Data also shows that 7-ketocholesterol causes cellular damage and induces oxidative stress in several types of cells, such as endothelial cells and cardiac cells, which was also seen in this study. And here is yet another way to look at oxidation as it relates to cardiovascular disease. These authors analyzed what's called 8-isoprostane, which is considered to be the gold standard for oxidative stress, particularly for lipids like those on LDL. In these figures, you can see clear correlations between this marker of oxidation and severity of cardiovascular disease, as well as risk factors for cardiovascular disease such as hypertension, diabetes, and smoking. And in our final way of looking at oxidation of LDL, we see something called myeloperoxidase, MPO for short. MPO is considered an important part of the innate immune system's antimicrobial arsenal. Antimicrobial as in, hey, there are bad bacteria or parts of bacteria here, let's sound the alarm and defend the castle. This enzyme has been implicated in the pathogenesis of several diseases, including atherosclerosis. MPO is ubiquitous in atherosclerotic lesions and contributes to the initiation and progression of the disease primarily by oxidizing LDL. In this paper, MPO levels were significantly associated with the presence of coronary artery disease, with 12 times the risk for coronary artery disease for the highest versus lowest quartiles of the leukocyte MPO, and 20 times the risk for the highest versus lowest quartiles of blood MPO. If you're not familiar with these statistics on average, these are very big numbers. Now we'll touch on HDL. And by the time we're done with this section, you're going to say, why didn't I know any of this before? This is the science. It's not a secret, it just gets lost within the system. So buckle up and let's spend a few minutes highlighting the importance of HDL. Now, normally, when you think of HDL, you think of the good cholesterol in your labs. Why? Because it plays a crucial role in reverse cholesterol transport, which means it helps shuttle excess cholesterol out of the body. But what if I told you that it plays many more roles than that, critical to the health of your vasculature? And what if I told you that your labs with HDL-C are not terribly predictive of cardiovascular health? What is important is healthy and functional HDL. From a lab perspective, it's more important to look at HDL-P particle number instead of just regular old HDL-C. Why is that? Healthy HDL is composed of many things. It's highly dynamic. It's been proven many times over to be an antioxidant, to include helping out with oxidized LDL, an anti-inflammatory, anti-thrombotic, and has vasodilation actions such as supporting the key signaling of the molecule nitric oxide. In addition to these wonderful attributes, it plays a key role in infection for bacteria, viruses, and even parasites. Let's stick with bacteria. Here you see healthy HDL with its normal complement of compounds. However, in infection/sepsis/endotoxemia, think dysbiosis and gut permeability, a high LPS-driven inflammatory state exists. HDL plays a huge role in blunting this inflammatory response. Here we see SAA. It's an acute phase protein, think inflammatory response, and LPS, which you know well by now, and LTA, which is the gram-positive bacterial version of LPS. In this endotoxemia example, HDL is working hard to do good things for you, so it gobbles up these mediators. But it comes at the expense of its normal components, which are cast off. A1 and A2 are the two main proteins of HDL, which play huge roles in its many functions. LCAT and CETP are crucial for reverse cholesterol transport. When this all happens, HDL actually becomes pro-inflammatory and pro-oxidative. And there is plenty of data to support this. So let's dig a bit deeper into the role of HDL in pathogen defense. It's important to know that in infection, in addition to the acute remodeling of HDL we just covered, that there are a number of lipid changes in the blood. For example, VLDL and triglycerides are increased, while HDL and LDL levels are decreased. This is an ugly combination. The LBP that I frequently bring up in my videos is an acute phase protein, again, inflammation, that helps eliminate LPS from the body with the help of HDL. In the healthy, LBP goes up with infection. But even though there is a drop in HDL, there is enough healthy HDL to take delivery of the LPS from LBP for elimination in the liver. However, in the unhealthy, the LBP goes up with infection. The already low levels of remodeled unhealthy HDL drop, and LBP now delivers more LPS to the macrophages of the immune system, resulting in more inflammation. Whereas healthy HDL actually has been shown to remove LPS from activated macrophages, blunting the immune response by yet another mechanism. LBP can also deliver LPS to LDL and VLDL, but HDL is the true superhero of this process. When this process is disturbed, as explained, multiple studies show that it is a poor prognostic factor for morbidity and mortality. Instead of this dysfunction mediated by a chronic LPS-driven inflammatory process, what you want are healthy, small, protein-rich and dense HDL cholesterol, acting as anti-inflammatory and antioxidant agents of reverse cholesterol transport, as you will now see. Let's look at just one of many studies I could have chosen. Here, 214 subjects aged 45 to 74 with stable coronary artery disease were followed for a median of 12.5 years. 36% died over that time span. Cardiovascular disease accounted for 2/3 of those deaths. When looking at HDL, you can see your usual HDL-C here. When breaking down their HDL-C into tertiles, thirds, they found no significant associations between HDL-C and total or cardiovascular disease mortality. In other words, high levels of HDL was no better than low levels of HDL when it came to mortality, statistically speaking. But when looking at HDL-P, that's the particle number, with these same thirds, we see a huge drop-off in total and cardiovascular disease deaths as the HDL-P numbers went up, which were all shown to be statistically significant. The authors state, quote, HDL cholesterol, that's the C version, is not an accurate surrogate marker to measure the cardioprotective functions of HDL in coronary artery disease patients. Here we have a study which simulates an infection or chronic endotoxemia for our purposes. Subjects with either high or low HDL were injected with LPS, and symptoms and inflammatory markers were measured out to 24 hours. In Table 2, you can see how those with the high HDL suffered significantly less from backache, chills, headache, myalgia, and vomiting as compared to those with the low HDL. Symptoms you may have during an infection. Maybe, instead of acetaminophen or ibuprofen, you maintain a healthy HDL profile. Now keep in mind, this is HDL-C, not HDL-P data, but the cohorts are also very, very different, in the lowest versus the highest 10% in HDL-C values. When looking at Figure 1, the solid circles represent the low HDL cohort. As you can see, their immune system was upregulated significantly more than those with the high HDL. Additionally, in this study, in Figure 2, all of these markers of inflammation were significantly higher in the low HDL versus the high HDL cohorts. Also, thrombin generation, think coagulation and clotting, was significantly increased in the low HDL group. To sum up this section on HDL, whether it's to maintain cardiovascular health or properly contend with an infection, it's important to have healthy HDL. If it is burdened by chronic inflammation driven by a dysbiotic microbiome, not only will the HDL not be able to carry out its basic function, with which you're familiar, exporting cholesterol, it will also become pro-inflammatory and pro-oxidative, and not be in a position to contend with a new viral or bacterial challenge when it arises. Think COVID, and how many people with diabetes and cardiovascular risk factors died from what was essentially too much inflammation. So now let's transition from some of the usual markers for cardiovascular health to a deep dive into the very strong but largely unknown connection between the microbiome and cardiovascular disease. Just a brief pause here in the presentation. If you could just hit like and subscribe, it would really help this channel out. In my videos, I'm always talking about the connection between dysbiosis, an unhealthy microbiome, gut permeability, and inflammation. Well, it's no different here. The same principles apply. If you're going to have a microbiome full of bad actors, they are going to do bad things, one of which is to poke holes in your gut, aka gut permeability or leaky gut. This allows pro-inflammatory bacteria or their components to escape into circulation. And this is basically what we zero in on in this section. First, we'll begin with a couple of good review papers. They spend a great deal of time talking about the pro-inflammatory connection between LPS, TLR4, which is toll-like receptor 4, that's the part of the immune system that recognizes LPS and screams invader, invader, and cardiovascular disease. You can see in the graphics here, they highlight the connection between LPS and thrombosis formation, arterial fibrillation, and heart failure. They even go on to state, quote, "Furthermore, studies in patients with severe atherosclerosis documented that LPS localizes in atherosclerotic plaque in close association with activated macrophages expressing toll-like receptor 4, suggesting LPS's role in vascular inflammation, atherosclerotic progression, and thrombosis." This paper we're talking about here comes from yet another 6 authors, this time out of Italy. Whether the authors are from Italy, China, Germany, the United States, or someplace else, the data is consistent. It is widely recognized that cardiovascular disease is a function of oxidation and inflammation. And I'm here to make the case that a large part of that is driven by a dysbiotic microbiome. And from our second and last review, we see another title referring to low-grade endotoxemia. That means a chronic exposure to LPS. In the healthy, the LPS burden is lower. It is cleared more efficiently, and the immune system is not hypervigilant. This paper highlights a slew of original research solidifying the connection between dysbiosis and all matters of cardiovascular disease. Whether it's the connection of LPS to thrombosis, atherosclerosis, atrial fibrillation, or heart attack, this paper cites reference after reference. And Figure 3 highlights visually the roles of LPS, oxidized LDL, oxidation, and inflammation. From the same review, Figure 4 does much of the same, except here for thrombosis formation. One of the reasons I highlight these graphics is to show you that this process, although may be new to you, is well established in the scientific literature. But all you hear about is statins, diuretics, and heart surgery. How about we think about an approach that perhaps doesn't benefit the pharmaceutical and medical device companies, but one that actually benefits you by addressing the root cause? So now let's take a look at the microbiome and a ton of evidence connecting it to cardiovascular disease. If you're familiar with my videos, you know this chart. So here we have the average microbial fingerprint for cardiovascular disease. And once again, the keystone taxa have very familiar sounding names. In cardiovascular disease, the classic oxygen, pH, antibiotic-sensitive butyrate producers like Erectile, F. prausnitzii, Lactospira, Roseburia, and Pneumococcus are significantly decreased in the microbiomes of those suffering from cardiovascular disease as compared to healthy controls. While we see the same bad-acting opportunistic pathogens we usually see, names like Enterobacter, Enterococcus, E. coli, Klebsiella, Aeruginovirus, and Streptococcus are consistently, significantly increased in the microbiomes of those suffering from cardiovascular disease. And once again, we see the genus Lactobacillus with a profile that looks like an opportunistic pathogen instead of a health promoter. You keep seeing the same names over and over again in my videos, and these taxa consistently have either a good or bad profile across all diseases and conditions. If you think that it's pure coincidence that F. prausnitzii always looks like this, and that E. coli always looks like this, and this is purely association without causation, then there's nothing more I can do for you. Now let's look at a bunch of data connecting the LPS you have come to appreciate as a pro-inflammatory cause for cardiovascular disease. Here we see a clear correlation between serum LPS and factor VIII, which is a blood clotting protein. The more LPS, the more clotting. Something you can imagine is not good in cardiovascular disease. And in part 2 of the study, not shown here, in an in vitro analysis, they found that this LPS-induced increase in factor VIII was blunted by a toll-like receptor 4 inhibitor. If you recall, TLR4 is the sensor for LPS. In other words, stop the LPS signal and stop the inflammation, which is basically our theme. In Table 4, we see a few variables to include various markers, various adverse cardiovascular events, and adherence to a Mediterranean diet. The diet did not change any of the blood lipid markers, but when it came to LPS, a high level of adherence was associated with significantly lower levels of serum LPS. This implies that a healthier diet improved the microbiome, which in turn reduced gut permeability. And what did this reduction in LPS escaping the gut result in? significantly lower levels of platelet activation, i.e. inflammation, i.e. coagulation. And by the way, in the highest third of LPS, there were far more major adverse cardiovascular events. Here we have a study using LBP. To remind you, LBP stands for LPS binding protein. It helps clear LPS from the body, so it's widely considered a surrogate for LPS. So just think of LPS when you see these two figures. Sepsis is when your immune system goes haywire in reaction to an infection, or for our purposes here, we're talking a gram-negative bacterial infection. As you can see, the LBP numbers for sepsis are the highest. No surprise. But the next highest is for those with coronary artery disease, which is higher than those without it. Again, LPS is driving an inflammatory response via toll-like receptor 4. And oh, by the way, if you read the text, you'll see that oxidized LDL upregulates TLR4 as well. We're talking about root cause stuff here. LPS and oxidized LDL driving inflammation. And from the same study, we can see a very clear stepwise progression of the odds for coronary artery disease as the levels of LBP increase. And if we look at the most important outcome, overall mortality, we see it graphed in figure B from these subjects who were followed for 8 years. For those in the fourth quartile, in other words, those with the highest levels of serum LBP, the risk of death was significantly higher, high enough for the authors to state, quote, LBP was a significant and independent predictor of total and cardiovascular mortality. Again, LBP is a marker for LPS. LPS is a marker for both gut permeability and abundance of gram-negative bacteria. Remember from my videos, not all gram-negative bacteria are bad, and not all bad bacteria are gram-negative. And the hyperinflammatory nature of LPS varies from species to species. However, even still, with the imprecise nature of these markers, the data is incredibly consistent, and it points back to an inflammatory response to gut dysbiosis. Knowing that blood pressure is really a canary in the coal mine for vascular health, these researchers compared the microbiomes and blood markers of those with high blood pressure versus controllers. Now, to me, the difference in blood pressure between the two wasn't much. They classified high blood pressure as having a systolic reading of equal to or over 140, while the controls were equal to or less than 130. But even with this small difference, we see once again incredible consistency in these trials linking the health of the microbiome to a given condition. In figure C to the left, we see my favorite compound, butyrate, which is significantly higher in the plasma of controls versus those with high blood pressure. We also see in A that the high blood pressure cohort has significantly higher levels of fatty acid binding protein. If you don't recall what that is, let me remind you. That's a marker for enterocyte, those are the cells that line your gut, cell death. In other words, gut permeability. Why are they dying? Inflammation driven by gut dysbiosis. Shown in B, we see significantly higher levels of LPS in the high blood pressure cohort. No surprise here, just more consistency as seen in every one of my videos, regardless of condition. And to the right, in C, we see significantly higher levels of zonulin in the high blood pressure cohort. Again, zonulin is that thing that helps drive gut permeability. And finally, in D, we see a dysregulated immune system as evidenced by elevated Th17 cells. For more on that, see my presentations on autoimmune disease. And for the last of our examples, we're going to drive home the message even more, this time from the perspective of subjects with impaired fasting glucose. Again, we see significantly higher zonulin driving permeability. This increase in zonulin was caused by dysbiosis, in part by LPS, which we see here. This is serum LPS, which means it has escaped the gut. Now, as always, we see that the healthy controls do also have a serum LPS level, but it is just significantly lower than those with glucose issues. This LPS and other factors can go on to drive the oxidation of LDL, which we see here, significantly increased versus healthy controls. And the LPS, oxidized LDL, and other factors can drive this here, which is a marker for platelet activation. Think more clot formation. The escape of whole or parts of bacteria, like LPS, just doesn't remain in the blood. In various videos, I show bacterial presence in tissue, like in the brain in my dementia video. Well, it's no different in the walls that line the vasculature. Here we have subjects with critical stenosis, which is narrowing of the carotid artery versus controls. We see in Table 1 that the only significant differences between the groups were serum LPS and zonulin. But get this, when looking at the tissue for LPS from E. coli, the worst form of LPS, the researchers found positivity for antibodies against E. coli LPS was greatest in the areas of immune activation, which leads them to saying, quote, "These data provide the first evidence that LPS from E. coli localizes in human plaque and may contribute to atherosclerotic damage via toll-like receptor 4 mediated oxidative stress." Again, oxidation and inflammation, the root cause, the purpose for our video. On the same theme, these researchers also looked at atherosclerotic tissue from confirmed coronary heart disease subjects versus controls. And what did they find? Bacterial DNA was found in all coronary heart disease patients, but not in controls and nor in any of the normal unaffected coronary arteries. If you look at Table 2, you see a number of the usual opportunistic pathogens I mentioned, species from Staphylococcus, Klebsiella, Streptococcus, and Enterobacter. Do you think maybe these proven bad guys are driving oxidation and inflammation in the vasculature due to their presence? And this whole bacteria, vasculature, cardiovascular risk story is not new information. You're probably familiar with people, and maybe you're one, who are given antibiotics prior to any procedure at the dentist, to include a cleaning. I'm not going to get into the merits or overuse of this, but it's done due to this very connection. If you look closely at the table, many of these bacteria are from the oral microbiome. And there are other studies that show the same themes. The more bacterial DNA in the atherosclerotic plaque, the more inflammation. And the higher the abundance of potentially pathogenic oral bacteria, the higher their abundance in the atherosclerotic plaque. So obviously, oral hygiene is important as well, a topic I do mention on occasion. In this interesting study, healthy subjects were injected with LPS. Why do they do crazy things like this? Well, in this case, to help prove once again that activated platelets and monocytes play an established and pivotal role in atherogenesis. As you can see in the three figures, these factors of platelet activation were all significantly increased with the injection of LPS, and all returned to normal after 24 hours. They state, quote, "In vivo administration of endotoxin leads to an early and significant activation of platelets and monocytes with a procoagulant response." But this isn't healthy subjects. Imagine, if you're not healthy, that you have dysbiosis, that you already have chronic levels of elevated LPS in your blood and your tissue driving chronic inflammation. It's really this chronic state which I spend most of my time highlighting in my videos. The heart attack itself is an acute event, but what led up to it? What led up to your acute problems with Parkinson's or dementia or Crohn's disease, ulcerative colitis, and the list goes on. Chronic degenerative disease is out of control globally. I work with people from many countries, and they are experiencing the same problems everywhere. It's no different with cardiovascular disease. You need to take control of the root causes of your inflammation. If not, you walk into events which are not a big deal to most of us, but can be deadly to you. Again, think COVID. Most of the people who died already had a hyperinflammatory immune system. If you watch my video on COVID, you'll come to learn that COVID and other viruses not only cause their own problems, but dramatically alter your microbiome for the worse. In fact, this ugly combination leads to statistics like, quote, "There is a 2 to 3-fold increase in the risk for acute cardiovascular events within 1 to 2 weeks after a respiratory infection. Or this one, quote, heart attacks are 30% more likely to occur during influenza seasons. Or lastly, this one, quote, in influenza patients, admissions for heart attacks were 6 times as high during the 7 days after laboratory confirmation of influenza infections. In other words, 20 admissions per week versus 3.3. In this paper here, LPS was injected into healthy controls, and a set of 89 cardiovascular markers were measured. Out of the 89, 54 were significantly increased by the LPS infusion. You can see a summary in this figure. And LPS is certainly not the only pro-inflammatory compound under the control of the microbiome. I now want to touch on 2 other important toxic compounds in the body which also connect the microbiome to cardiovascular disease and more. These 2 compounds are called P Cresol and uric acid. You may not know them by their names, but you probably know them by the problems they cause. P Cresol is highly problematic in chronic kidney disease, and especially if you're on dialysis, which is in part why the recommendation exists for less protein consumption. However, it is also highly problematic in cardiovascular disease. The other toxin we'll highlight is uric acid, which is the cause for gout. So if you have gout, pay extra close attention. But it's also highly problematic in cardiovascular disease because, as I always say, it's all connected. So how is it that the microbiome, uric acid, and cardiovascular disease are connected? Well, it's common knowledge that uric acid is problematic from purine-rich foods like alcohol, red meat, and seafood. But another abundant source could be fructose metabolism from the liver. See my video on liver health for more information. There are many studies showing a high correlation between uric acid and all facets of cardiovascular health. So, is this just correlation, or is there some proof of causation? Well, here too, there is a great deal of data showing that at higher levels, which drive intracellular uric acid accumulation, it is pro-oxidative and pro-inflammatory. This disruption occurs via several mechanisms, to include the very important nitric oxide, which results in a disturbed balance in vascular dilation and constriction with a subsequent immune response. As it pertains to the microbiome, it's important to note that although about 2/3 of uric acid is excreted via the kidneys, about 1/3 is excreted via the gut. And the microbiome plays a large role in this balance. In fact, many studies show that the microbiome is disturbed in hyperuricemia, which is high uric acid in the blood. From this particularly interesting one, we have a few findings. But first, let's understand some enzymes. In figure A, we see urate, which is uric acid, which is produced by the enzyme xanthine dehydrogenase. Now in humans, this is the last step. Uric acid from here has to be excreted. But the microbiome possesses other enzymes able to process uric acid, like these 2 here. Now, if we look at figure C, we see gout in red and healthy in green. There are huge differences in the presence of these 2 enzymes. So, in the dysbiotic gut, you have an overproduction of the enzyme which makes uric acid, but an underproduction of the enzymes which process it to urea. And not surprisingly, we see some familiar faces. Although in the gout-dominant microbiome, we don't see any classic opportunistic pathogens here, but in the healthy control microbiomes, we do see that they possess significantly more classic health promoters. And if you're familiar with my videos, the names Carpococcus, Faecalibacterium, Ruminococcus, Odoribacter, Subdoldigranulum, and Allostipes should ring some bells. The gout microbiome is missing or reduced in the abundance of good guys, which is consistent across all disease states I've covered. And not shockingly, these researchers found that the gut microbiota of gout was characterized by significantly impaired butyric acid synthesis, while other researchers have found that butyrate availability in the gut helps excrete uric acid. while even others have found that uric acid increases gut permeability. And we already know that butyrate helps reduce gut permeability. And we can see the connection between serum uric acid and cardiovascular disease mortality quite clearly from this massive review of over 1.1 million subjects. As levels of uric acid increase, cardiovascular disease mortality does with it, and it especially jumps at about 6 milligrams per deciliter. This is in line with another large meta-analysis, which indicated for every 1 milligram per deciliter increase in serum uric acid, there is a 20% increase in coronary artery disease mortality. And in each paper, the authors talk about the oxidation driven by uric acid, to include the oxidation of LDL, which we covered earlier, and the ensuing inflammation which follows. So, it would be wise to take good care of your microbiome so it can in turn take good care of you by helping to manage the levels of a pro-oxidative toxin floating around in your bloodstream. Now let's cover the second of these toxic compounds, P Cresol. As I often say in my presentations, the bad bacteria tend to like to ferment proteins, and the good bacteria tend to like to ferment the sugars locked behind bonds, what we're generally referring to as prebiotics. So here is more evidence of that. Again, I'm not advocating a vegan diet at all, but I'm also cautioning against this current carnivore diet fad. Invariably, some amount of protein will make its way into the colon each day, mostly from the diet, some from us. As we know, the microbiome possesses thousands of enzymes, far more than we do. Some of these bacteria break down the amino acids tyrosine and phenylalanine to P Cresol. From there, P Cresol can be metabolized to one of two compounds, P Cresol glucuronidide or P Cresol sulfate, the toxic version, which in the serum are bound to plasma albumin and under normal conditions excreted via the kidneys. We know the source for these is the microbiome, because hemodialysis patients without a colon have the same plasma P Cresol sulfate levels as healthy subjects. And there are a number of studies showing that prebiotics reduce P Cresol levels. This is why patients on dialysis are told to decrease protein intake, because by decreasing protein intake, you're reducing the amount of these two amino acids, which can be fermented to P Cresol. But you can also address the root cause, the microbiome. You can alter the composition of the environment of the microbiome. You can change the factors that determine microbial end products and ferment more short-chain fatty acids and fewer toxins like P Cresol. Now, this toxic presence of P Cresol sulfate is a huge burden on those with kidney disease. Their serum concentration is about 17 times higher because hemodialysis can only remove about 30% due to the bond with albumin. And returning to our cardiovascular disease theme, guess how most dialysis patients die? From cardiovascular disease. Studies show that elevated levels of P Cresol sulfate are associated with increased mortality in patients with chronic kidney disease and an increased risk of cardiovascular events. As we can see here in Figure 4, the higher the serum P Cresol, the much higher the death rate due to cardiovascular events. So why is this compound, which is toxic to the kidneys, toxic to the heart? Well, because it's a toxin in circulation. Cresol is a widely used disinfectant, also present in coal tar, resins, pesticides, and industrial solvents. As a toxin, it is pro-oxidative, as we can see here in A and B. You can read their conclusion at the bottom. This comes back to our theme of oxidation and inflammation being the cause of cardiovascular disease and pretty much most everything else. The vascular changes induced by P Cresol include arterial calcification, atherosclerosis, arterial stiffness, and platelet and leukocyte activation. Think inflammation and clotting. It is for these reasons that P Cresol is suspected to be the driving force behind cardiovascular deaths in chronic kidney disease. So whether you have chronic kidney disease, heart disease, or simply want to remain healthy, you can modify the fermentation end products in your gut for the better by intelligently altering your microbiome. On that note, let's take a look at 4 interventional studies and see if this philosophy of addressing cardiovascular disease via the microbiome really works. First, we'll start with a couple of FMT, fecal microbiota transplant studies. I have a whole video dedicated to fecal microbiota transplants. Here we have three aspects of looking at the microbiome's impact: the direct effects on uric acid on cardiovascular health, as we covered earlier, the benefit of FMT on gut permeability by improving dysbiosis, and the benefits on gout flares. Here we see significant improvements in serum levels of uric acid solely by changing the gut microbiome by FMT. And here we see significant improvements in gut permeability as measured by serum endotoxin levels, aka LPS. And finally here we see significant improvements in gout flares, both for frequency and duration. Now, if you have gout, you won't be able to feel improvements in serum uric acid levels or LPS levels, but you sure will be able to appreciate significant improvements in gout flares. As we learned, hypertension is a strong independent risk factor for cardiovascular disease. It's a good measure of the health of the vasculature. With this in mind, these researchers intervene with FMT in these supposed hypertensive subjects. I say supposed because if you look here, they didn't have what seems like high blood pressure at 126/78. Nevertheless, it was significantly higher than the controls. And what did they find? All 260 subjects underwent at least one FMT procedure, while 72 of them underwent at least two. In Figure A, you can see how following the first FMT, the changing of their microbiomes, both systolic and diastolic numbers went down significantly. And even in the normotensive subjects who started off with a reading on average of 120/75, they too had a significant improvement in diastolic blood pressure. Now, FMT is a bit extreme. It's highly effective, but so is supporting your microbiome with an intelligent blend of properly dosed prebiotics specific to the needs of the individual. In this trial, they did not use a blend like I do. They did, however, use resistant starch, which is one of the prebiotics I recommend. They used 40 grams of it per day, which is no small amount, but also not unheard of in trials. So what happened with these NAFLD subjects after 4 months on therapy? Well, a lot. By administering resistant starch, which clearly only influences the microbiome, we see some very impressive results. In Table 1, we see significant reductions in total cholesterol, triglycerides, and LDL cholesterol, with a significant increase in HDL. Continuing, we see significant improvements in fatty liver, total weight loss, subcutaneous and visceral fat, liver function tests, serum LPS, and inflammation as represented by TNF-alpha, another marker which I frequently mention. Imagine how popular a drug would be if it could do all of this. In this last study, the researchers used two more products I recommend and properly combined with others, inulin and sodium butyrate. In these 60 overweight and obese diabetic patients, the study only lasted 45 days. And once again, we see great outcomes. In Table 2, we see significant improvements in inflammation as measured by CRP. We also see significant improvement in something called MDA, which is a marker for lipid peroxidation. This goes back to the beginning of this video in regards to oxidation and oxidized LDL. From the same paper, we also see in Figure 3 a significant improvement in inflammation as measured by TNF-alpha. And in Figure 2, we see significant improvements in both systolic and diastolic blood pressure. I realize this was a lot of information, but cardiovascular disease is the #1 killer globally after all. So what do you do with this information? What I don't recommend is running out and buying a bunch of antioxidants in an attempt to reduce oxidation. That's old school and will probably not work. I don't recommend running out and buying anti-inflammatory supplements either. I work with many people from around the world, and I often take them off as many supplements as I recommend. The use of supplements ranges from possibly harmful, to plugging holes in a bursting dike, to outright uselessness, or to simply not addressing the root cause. I'm about addressing the root cause. I think I showed you plenty of data to state my case. You're welcome to read any of the references I cited. So if the data shows that our conventional way of viewing HDL and LDL aren't predictive of mortality, while markers of oxidation and inflammation driven by dysbiosis are predictive, then I'm going to go out on a limb and suggest a new way of viewing cardiovascular disease. Perhaps it's time to try something more intelligent. Well, I hope you enjoyed that video, and I will say that basically every single day on my YouTube comments and in emails, I get a lot of thanks from people out there who really appreciate the information I've been sharing. And so part of that is you're welcome. The other part is you can contribute by clicking on the super thanks below. And if you're not doing a consultation with me and you're not purchasing any protocols, it's a great way to support this channel. Each presentation, depending on the presentation, but most of them take an incredible amount of time to put together. There's a lot of material. There's a lot of data checking. And so it's just sometimes 50, 60, 70 hours to put together one presentation. And so if you can just click that super thanks, I'd appreciate that, and we'll keep the information coming.